You know, I was just really kind to the YouTube audience. I waited for the recording in progress to sound before I started speaking. And that's the only kindness you'll get from me this in the year of 2025. Welcome everyone to another RLR edition of VMR. We're very excited to be here. Robbie was actually on a night shift. They didn't sleep at all. But if you look at his face, Robbie, say something so the YouTube fans can see you.
Hello.
Say hi to the YouTube guys and girls.
Wait.
Oh, now you're muted,
Oh,
but
wait.
we
One
were
second.
hearing you.
Hello. Can you hear me now?
Yeah, we can hear you. We see you, and that's fantastic. We have amazing case presenter, Zachariah. Zachariah, unmute yourself, say a few words. Zachary, hopefully this is the only mistake you make today, but you're still muted.
Oh gosh. Oh gosh. Hi everyone. I'm Zakaria G from South Africa, and yeah, really excited to present another case.
Welcome back, Zachariah. It's been a minute. Nice to see you, my friend.
Same here.
Who's scribing today? I feel like the scriber is always the person we don't thank enough. Who's scribing? Wow,
I'll
we
be
have
doing
an
this.
anonymous scriber. That's incredible.
Yes, my name is Glenn. I'll be doing the scribing today. So I'm from Botswana, neighboring country to Zakaria, South Africa.
Glenn, you're a new face. I haven't met you yet. How did you get involved in CP solvers?
Uh, it was a few months back. I then took a break to take step one. It was through Mark. Mark actually came here to visit. Then introduced me to CPS.
Well,
Yeah.
thank you so much. Thank you so much for being here. We're really happy to have you. Um, Dude, my dad just came out of the cold winter in Pittsburgh and said, "Look how cold I am," and touched my mom in the face. Is that some kind of abuse?
Easy there, bro, friends.
Who's
I,
te who's teaching today? This is who's teaching today?
Hello, Prof. Rez. Eugene
Oh,
here.
Eugene. How are
I'm
you?
I'm doing great. How are you?
I'm well, Eugene. Every time I see you, I think of some of the most fascinating, intricate cases that you've presented. It's so nice to see
Yeah.
you. I see you got the Christmas cheers in the background. Happy
Yeah.
holidays.
Happy holidays.
All right. So, for Robbie's sake, why don't we get this case started? This poor guy needs to go to bed. Um,
Professor, can I
and
interject? Because
please.
I don't think this has ever happened before, maybe happened once before. For the longest time, we had absolutely nobody from the continent of Africa and the CP solvers, and now the entire group, from the scribe in Botswana to the case presenter in South Africa to the teaching points in Ghana, is representing the awesome content, which is just so cool to see. So, yeah, I'm wide awake to remember that, and then I think everything's going to be downhill from here. So
Yeah,
take it
that
away.
means we got to take a trip out to Africa.
100%. That'd be so cool.
Eugene, invite us.
Yeah, I will.
All right, Zachary, mic to you, my friend.
Okay. Hello everyone. Okay, I'll just wait for the whiteboard to come up, and then we'll start. I'm seeing that Glenn has started screen sharing, but I'm not yet seeing the whiteboard up. I'm not sure if that's just for me or.
No, I think it's the same. I wonder if there's a little friction in Glenn's connection there. Fine. Okay, alrighty. To no surprise, Lyra is coming to the rescue and sharing her screen, I think, based on what she just did. Thank you. Thank you, Lyra. Alrighty. I will stop Glenn's share, and then here we are. All right, then you can sit back and relax. And I think Lyra's sharing her screen, so feel free to take over the scribing. All right, Zachary, we're ready whenever you are.
Wonderful. Yeah, so a couple of months ago in clinic, a 32-year-old male came in, and his words were almost exactly along the lines of, "Doc, perhaps you're my last hope." And this was a 32-year-old male who presented with a history of recurrent gastrointestinal bleeding and chronic pancytopenia. So he started having symptoms back in 2016 and had easily had more than 10 to 15 platelet transfusions over the last 10 years. In terms of the bleeding history, there were episodes of vomiting blood, episodes of what sounded like melena, and episodes that sounded like hematochezia. But he reported no history of any epistaxis, gum bleeding, or easy bruising. And his systemic here examination otherwise was unremarkable. And I'll stop there.
Zachary, I'll just say that I think you're probably going to be many people's last hope, given how invested you are in medicine and how thoughtful and dedicated you are. I will say that there's two problems here. There's the GI bleeding and the pancytopenia. And I think that there is very few things that reflexively connect those two things. So the thing that I'm naturally doing is to focus on each of them and try to solve them separately. And I will just say one thing about this, which is that the pancytopenia is much more certain than gastrointestinal bleeding. I would share with you that even though gastrointestinal bleeding is a very common diagnosis we make, it's one that is made with significant difficulty, in large part because the gastrointestinal tract is not visible, and only time that you know somebody is having gastrointestinal bleeding is when you literally see it through endoscopy. Many times we don't know where the blood is coming from. Is it coming from the GI tract, GU tract, lungs, GYN tract? And many times we're not even sure whatever's coming out is blood. So the pancytopenia here is certain. The GI bleed here is questionable. And so I would be asking myself, how do I work up pancytopenia with the possibility that I'm being distracted by the idea that the patient's bleeding when they're actually not, or maybe just oozing from low platelets where the GI isn't really holding the disease. It's merely manifesting a consequence of the thrombocytopenia. So if you ask me, the pancytopenia grabs my attention way more. The GI bleed may be a distractor or a profound clue because it's such an unusual combination. So that's where I'm at, Prof. Rez. I'm curious where your mind is investing energy.
I love that so much, Robbie. I think it's such an elegant way to solve this case. And we already know that pancytopenia, like you can have borderline pancytopenia and then you can have severe pancytopenia. And rather than share an approach yet, it's going to be really interesting to actually see the counts and see how severe they are. And then we can go from there. But yeah, I'm right there with you. It is interesting that the symptoms have been going on for almost a decade now. And I think it's really important for us to track that time course because it's heavily influential on the types of diseases that sort of last chronic to progressive, as opposed to like a acute leukemia that is much more robust in its presentation.
Yeah, absolutely fascinating and such an interesting discussion. And I can tell you that in terms of his background history, his family history was unremarkable. He'd been well as a child. In terms of health-related behaviors, he didn't drink alcohol, didn't smoke, didn't use any drugs at all. And in terms of his chronic medications, he was only on iron and folate supplementation. In terms of his vitals, the vitals were completely normal, but he was quite pale. And but otherwise, he looked quite well. He had no lymphadenopathy at all, no signs of chronic liver disease on physical exam. He wasn't jaundiced, and he had no peripheral edema. And his cardiovascular, neurological, and respiratory exams were all completely normal. On abdominal examination, his abdomen was soft, but distended, but non-tender. And he had hepatosplenomegaly with a particularly prominent massive spleen, and he had no clinically obvious ascites. And I'll stop there.
Yeah, this is so helpful, Zachariah. And I think just for the interest of teaching, it's really the approach to cytopenias can be simple, very easy to simplify. If you have one cell count that's down, it's most likely you're either dealing with loss or peripheral destruction. If you have three cell lines that are down, it's more likely that you're either dealing with a marrow problem, most likely marrow, or a splenic sequestration problem, where the spleen indiscriminately will absorb a bunch of the cell lines. When you're dealing with two cell counts, it could be either or, and you have to entertain both possibilities. But in all things of medicines, there's exceptions. You can have all three cell lines down and have a peripheral destructive process that may occur with CLL or lupus or tick-borne diseases. The other interesting thing is that this guy is really pale, which speaks to the degree of their anemia. It's going to be quite low. And you don't know how much of that is the process happening in the spleen or not or, but and the actual blood loss happening through the gastrointestinal system. I think this exam is so helpful, and it sort of speaks, Robbie, to the chronicity of the problem because we have someone that's going to is going to be quite anemic, but has a normal heart rate. So we know this didn't happen overnight, and the body and the cardiovascular system had enough time to adjust to their new normal, that this slow process brewing. And then the lack of stigmata of cirrhosis is actually not helpful at all, guys. It doesn't have much of a negative predictive value. But if you had this stigmata of cirrhosis, which you can just simplify to portal hypertension or elevated estrogen levels because the liver is not functioning, or elevated bilirubin, you might see stuff like spider angiomata, palmar erythema, and in a man, testicular atrophy. These reflect high estrogen levels, or findings of portal hypertension, which may manifest with a distended belly like this patient has, distended abdominal wall veins, caput medusae, or stuff that you might see on cross-sectional imaging or endoscopy, and that is dilation of vessels in the esophagus. So I don't think we can say this person doesn't have cirrhosis with the lack of findings, but if they had findings present, then it would really predict the possibility of cirrhosis. I think what Zachariah did for us here, and I'm going to pass the mic to Robbie to discuss the differential diagnosis, is he's saying, look, this person's pancytopenia is in part due to this massive spleen. So you have to keep asking the question, why? And what Robbie's going to do for us now is answer what can cause the spleen to be so massively enlarged. I'm not dismissing that some of the anemia is not from GI bleeding, and I'm not dismissing that there can't be a concomitant marrow process, but we have a clearly positive finding of the spleen. So you can link those two easily together. So this is where it's worth investing your cognitive energy in asking what causes splenomegaly, which is likely leading to this patient's pancytopenia in big part.
No, Prof. Reza, I'll just spontaneously speak. I absolutely co-discuss. I love co-discussing with you because I think what nobody else does like you is just really crystallize the problem calmly and with such tremendous clarity that following you and now focusing on the spleen is effortless. But I just want to take a moment because I spotted somebody in the audience who I haven't seen for a long time, Carolyn Kaufman, who joined VMR as a fourth-year medical student and is now, I think, a second or third-year resident at Stanford. It's very, very nice to see you here. Anyway, yeah, Prof. Rez, I think what we know now is that this disease isn't hidden, that it's taking up space. And I think you can even zoom in on the details of splenomegaly and what takes up space in the spleen. But I think since the liver is involved, my mind is inclined to sort of deploy an approach to like organomegaly and ask what makes organs big. And I think there is an inherent assumption in that word organomegaly that there is symmetric enlargement of both organs. Just 2 or 3 days ago, Prof. Rez, I was fooled into thinking somebody had hepatomegaly, and I'm easy to fool because my physical exam skills are abysmal. And they actually had a large liver mass. So before you deploy your organomegaly schema, you have to recognize that you're making the assumption there's homogeneous enlargement of the organ and that you may be fooled that there's a focal mass. The truth is that that is unlikely when there are two simultaneous organs involved. The probability of two large masses fooling you is low, and it's also rare to have a focal splenic mass in general. So I think it's wise to really deploy that organomegaly schema here, recognizing that caveat of focal mass is diminished. So what makes organs big? And I think fundamentally, it's actually a very simple concept: congestion or infiltration. Is there water making the organs very, very big, or is there infiltration by something? And that something can be very, very complicated. And you'll see the schema on our website for splenomegaly essentially zooms in on that concept, where we emphasize that the base rate would suggest congestion with fluid backing up from the portal circulation. And then the rest of the schema on the right side is everything that can infiltrate. The spleen divided by the cell that's infiltrating. White blood cells, red blood cells, and then some nod to the idea that cells may not be infiltrating, but microscopic accumulation of proteins or substances may be accumulating. So what progress can we make on the fact that the liver and the spleen are simultaneously involved? I think that the truth is, unfortunately, the progress that we can make is very minimal because congestion is very plausible, but it localizes the lesion of congestion to being past the liver. So if there is congestion happening, then that congestion would have to be post-hepatic. So it diminishes the probability of where congestion can occur in the pipes and really limits it to the post-hepatic space. What would allow us to make progress is to study for whether there are other clues to help us figure out, is there water or is it organomegaly? Is it infiltration? And I'm really eager to see with a simple bedside tool like POCUS to see if the patient has fluid in their belly. Because the presence of ascites in this context can be consistent with an infiltrative process, but when you're seeing water in the belly, I think it's easier to make the leap that there's water in the liver and the spleen. If you see other forms of organomegaly that are not in the pathway of the hepatic vein, so if you see lymphadenopathy on the surface, or if you see gosh, I'm trying to think of what else you could see. If you see something in mediastinum, like a mediastinal mass, that'll break the symmetry and help you prioritize infiltrative. So to summarize, Prof. Rez, I think I'm not zooming in on the details. I think the question I'm asking is this water, is this infiltration? If I see water in the belly, I'll probably start to lean stronger to water, and then I'll tap that water to confirm that in fact it is pure water with very little albumin in it. If we don't see water, and instead we see space occupation in organs that are not on the downstream of the drainage of the liver, then I'll be like, infiltration. And I'm not really going to invest too much in what could be infiltrating when congestion is just as compatible hypothesis. Finally, I know I'm talking a lot, but let's not leave the time course. The time course here is chronic. What's more likely, chronic congestion or chronic infiltration? I have some thoughts on that, but I leave that to the reader or the listener to decide. I think it's congestion. But we'll see. Mike to you, Zachariah.
Yeah, just brilliant. And yeah, in terms of his initial lab work, as you can imagine, this is 10 years worth of lab work. So I can tell you that his white cell count was persistently between 0.8 and 1.8 over the last 10 years, with neutropenia and lymphopenia on the differential, and no eosinophilia or any other abnormalities. His hemoglobin was persistently less than 8, sometimes as low as 4 to 5, and he often got transfusions. And his MCV was persistently microcytic. In terms of his platelet count, it was also persistently less than 50, sometimes dropping as low as 20. In terms of the iron studies, the ferritin was between 5 and 16, and the serum iron was persistently low, as well as the transferrin saturation persistently between 3 and 5%, with a slightly low reticulocyte production index. And in terms of the blood smear, there were some occasional pencil cells, some occasional teardrop cells, no spherocytes, no schistocytes. and a bone marrow biopsy and a histology that had been done in 2016 showed absent iron stores, no dysplasia, no increase in blasts, no malignant infiltrates, and showed that the bone marrow was actually markedly hypercellular for age. And I'll stop there.
Professor, I spoke so much. I really, really love your wisdom on this data. I think there's Professor's magic coming our way.
First, I want to thank Zachariah for just presenting this so well and really giving us a great opportunity to analyze and try to solve this case. Thank you, Zachariah. You know, it's interesting when you practice enough medicine, see enough patients, you end up having a reflex to what can be happening. And there's like a really important concept in clinical reasoning referred to as the law of proportionality. And I've taken care of a lot of patients with cirrhosis. And in those patients with cirrhosis, portal hypertension, the counts are low, but they're not this low in the group that I've taken care of. Now, I'm always flexible once there's a common disease, saying that this could be an uncommon presentation of something common, but just sheerly based on those cell counts, it would make me wonder if this process was invading both the liver, the spleen, and the bone marrow. And I think in 2016, they did a really good job of doing a bone marrow biopsy. Now, whenever you do biopsy of a tissue, you're either going to get an answer, you're either going to get a negative result, or you're going to get a questionable result. What I mean by that is that the questionable result is when you sample a part of the bone marrow where there actually isn't disease. So you're not going to have a great understanding of what is happening. So appropriately, they're like, whoa, this is severe pancytopenia. We're going to focus on the marrow. Let's go and sample the marrow. And just to quickly dismiss the iron stuff, what it's telling you is the ferritin is low, so the patient is iron deficient, most likely from this recurrent gastrointestinal bleeding, which is probably in the context of the thrombocytopenia, but he may have some kind of lesion within the gastrointestinal lumen that's vulnerable to bleeding with such low platelets. So they biopsy this and they're asking the question, well, are we dealing with blast? Could there be a leukemia? Are we dealing with something that's non-cancerous, like a granulomatous infection, for example, that's infiltrating, or some kind of other disease that's replacing the marrow? But what did Zachariah tell us? And this sort of principle is highlighted in endocrinology by Tiago. He says this all the time, is what would you expect the bone marrow to do if your cell counts were low? Like, what would be the appropriate response of the bone marrow, assuming it had all of its machinery? It would be to increase the cell count. And the bone marrow on that biopsy, Zachariah told us, was hypercellular, but he said they're not abnormally shaped and there's no cancer cells that the pathologists witnessed. Of course, they run flow cytometry and try to understand the surface antigens of those cells to see if they're abnormal or not. And Zachariah also told us that there's teardrop cells in the peripheral smear, and those teardrop cells usually indicate that something's invading the marrow. So there's two possibilities here. Either something is invading the marrow, weakening the marrow, and we just didn't biopsy the right site, or the marrow is actually untouched and it's doing everything in its power to compensate for whatever's happening outside of the marrow to synthesize these cells. So what do we do here? Remember, this bone marrow biopsy was in 2016. A decade has passed. So I think if this patient was coming to the hospital, I would acknowledge the bone marrow biopsy. But I bet you back then he didn't have this massive spleen and enlarged liver that Zachariah palpated on physical exam. I think my next step would be the following: to get a peripheral smear, to send a peripheral flow cytometry, and if possible, to get cross-sectional imaging of the abdomen and pelvis. to investigate, like, is the liver actually enlarged? How large is the spleen? Is there any fluid? And then to not say that, hey, because we did a bone marrow biopsy a decade ago, this patient doesn't need another bone marrow biopsy. Yeah, that's sort of where I am, but I'd love to hear from Rabih as to what he's thinking.
No, Professor, I am right there with you. And I think the question that I'm grappling with is, in addition to that, is what is the value of the iron deficiency? And I think just to go back to the original conversation, yeah, I think it really, when somebody is having overt stuff coming from the GI tract and you find they're iron deficient, now I think we have to add true gastrointestinal involvement to our list. So I think you are on the hunt, making a very powerful argument for why the patient might have marrow disease. Based on Zacharia's astute physical exam skills, we suspect the liver and the spleen to be implicated in this disease. So now if I'm making a list of organs, liver, spleen, query marrow, high concern based on what you just articulated, and then now query GI, high concern based on the additional finding of profound iron deficiency. And so if we go back to that framework of congestion versus infiltration, like it's hard to invoke the idea that the marrow is congested, right? So if the marrow is in fact involved in this disease process, which we're still on the fence about, we need that repeat marrow now. If it is involved, we know it can't be congested. And so does that push us to completely discard the congestion hypothesis? Maybe, maybe not. For me, it doesn't. And the reason why is I'm literally visualizing a traffic jam. And that traffic jam is making the liver big, making the spleen big. What would further support that is there's fluid in the belly. And then making the intragastrointestinal luminal veins big, causing bleeding in the stomach. Portal hypertensive gastropathy is one example. So I can literally imagine how that traffic jam is radiating from the either portal circulature, portal vein, hepatic vein, making everything back up into the gastrointestinal tract. It's hard to link in the marrow with that, but when you just have one piece of knowledge that marrow diseases result in a wide variety of portal vascular or hepatic vein diseases. As an example, we just had on Wednesday, Kritika present a case of polycythemia vera resulting in portal hypertension. So there are connections in that route. So I, like you, I'm suspicious the marrow is involved. I'm also suspicious the stomach or the GI tract is involved. And just because we have built momentum for this, the marrow being involved, making congestion unlikely, I am open to there being two separate mechanisms. Infiltration of the marrow as evidenced by the teardrop cells. But there are diseases that infiltrate the marrow that paradoxically cause congestion centered around the portal and hepatic vasculature. And that one piece of knowledge is making this case incredibly complex because it's making my mind struggle with trying to find a unifying mechanism, infiltration or congestion, because there's very plausible reason to suspect a scenario where both are happening at the same time. So long story short, I'm now 14 hours straight of clinical medicine, and Zachariah is making my mind go in a tailspin. I'm excited for all of you to watch me fall and collapse, but I think Prof. Rez will rescue me at the end. So that's where I'm at.
Yeah, I think I need to say to people in the audience who haven't presented cases yet, is this is why you should come and present cases on VMR, because the amount that I am learning from this case that I thought I knew is just remarkable. And yeah, just a small encouragement to please present cases if you haven't yet. In terms of further blood work, patient's B12 was persistently mildly elevated, folate normal. His INR and PTT were persistently normal over the last 10 years, and his albumin was chronically low, between 2 and 3. He had intermittent, mildly elevated conjugated bilirubin, but it was very, very mild. And his liver enzymes were unremarkable, with occasional increases in the ALP and GGT that would then sort of self-resolve. And again, very, very mildly increased. In terms of his renal function, his creatinine and GFR were always normal, and he had a very borderline elevated urine protein to creatinine ratio. His ANA was negative, his Coombs test was negative, and his endocrine workup showed a pattern consistent with mild primary hypothyroidism. And one more thing that I'm going to share is I didn't actually plan to share it initially, as we don't have a full report, but I can share one CT abdomen image that might prove useful. Okay, let's know. And I will stop there.
This is a very big liver and a very, 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 very big spleen. Yeah, I think it just confirms the sense that the organomegaly is real. I didn't see any focality, and I also didn't see any fluid in the belly. And I think those things are the things we mentioned. So those are noted. And I'll pass the mic to Prof. Rez, see what he made of the labs.
Thank you. And Zachariah, was there ever fever documented or no fevers in this past decade?
No fevers, no weight loss or constitutional symptoms
Yeah.
at all.
Yeah, I think this is super, super helpful. I think you can't let go of the time course and you can't let go of this patient's age. He's 32, and for a decade, he's been dealing with this problem. And as Robbie said, the lack of ascites really lessens the probability that you have this really significant congestion happening beyond the liver. So now you have enlarged organs, the liver, the spleen. And I think that simplified approach of congestion versus infiltration versus inflammation, I think you had inflammation in there too, but the patient isn't really inflamed. Um, the low albumin here, Zachariah, is quite interesting to me because generally, when someone has a low albumin, the most common culprit is that albumin's a negatively acute phase reactant. So someone's inflamed, their albumin is down, or they have cirrhosis, but there is no evidence of cirrhosis based on the INR. I mean, the bili is slightly elevated, but there's no ascites, there's no portal hypertension. And so then the question becomes, what else can cause the albumin to be this low? And we didn't get a report that this patient's losing a lot of weight or is cachectic. So I'd be really interested in what's happening on the in the UA. And here Zachariah listed the UA as borderline high. So probably losing some protein in the UA. What I'm trying to get at is like it's almost like we're making an acronym here. Like we're listing stuff like thrombocytopenia, anemia, fibrosis potentially of the bone marrow. And so I'm like wondering if it's a young person, is this some kind of genetic disease like a Tafro-like syndrome? Whatever it is, it just seems like it's a syndrome. And I think to answer this, you're going to need tissue, at least for me. I Robbie may already know the answer, but for me, you're going to probably need tissue. And the question is, where would you biopsy? And whenever that question comes up, I would send an ESR and CR. I'm just very curious to see if there's any inflammation at all, because if I can frame this as like a non-inflammatory, decade-long process in a young individual with organomegaly and severe pancytopenia, that sort of changes the frame. But you're not going to biopsy the spleen. The question becomes, do you go after the liver? Do you go after the bone marrow? To see if you can get another part of that acronym that's consistent with this presentation. We already have a bone marrow from 2016, but honestly, I might actually go after both. I might start with the bone marrow because I know that reticulin fibrosis and TAFRO or a TAFRO-like syndrome. So what I would do is GPT that right now, 32-year-old hepatomegaly, splenomegaly, severe pancytopenia, no evidence of congestion. What can it be? And probably kidney involvement too with that low albumin. But would love to pass the mic to you, Robbie. The reason I asked about fever was just like thinking of Tafro, but it's just giving me that flavor of like a Tafro-like syndrome.
Yeah, my mind is also like, hey, there's fibrosis in this marrow. I'm right there with you. And I think tafros is such a beautiful explanation and a really real possibility. You know, Prof. Rez, can I tell you, my mind went to a very beautiful moment we shared in 2018 or 2019. And you're gonna, I'm sure you have a high chance of remembering this. Do you remember on Twitter when we used to get into Twitter arguments with people, we got corrected about the lack of ascites arguing against portal hypertension by somebody who reminded us that prehepatic portal hypertension has no ascites. Do you remember this? It was like a very angry correction of one of our schemas that was teaching about how ascites was like a feature of all portal hypertension. This person reminded us that isolated splenic vein thrombosis or whatnot doesn't cause
And I think was it an ID fellow?
I think, oh yeah,
Like
that's
a
right.
female
That's right.
ID fellow, and
That's
we're like,
right.
and we just yeah.
That's so right. Yeah, I think we actually, I subsequently met him in real life. He's very, very nice, but our conversations weren't very pleasant on Twitter then. You know, the only reason I'm bringing that up, Prof. Rice, is I think if we're mathematical, the lack of ascites significantly reduces the probability of all forms of portal hypertension except prehepatic portal hypertension. Can I tell you why I'm holding on to the possibility of prehepatic portal hypertension? Because it causes such massive splenomegaly, because all that pressure builds up and just affects the spleen and it affects the GI tract. Because the difficulty I'm having, Prof. Rez, is every theory that I'm thinking of is like, why would it affect the GI tract? And we have two arms of proof that GI tract is involved, both overt blood loss and the iron deficiency. So what I'm really itching to do in real life is go forward in time exactly as you proposed. But I'd also be interested to go back in time and be like, what were those endoscopy reports? Did they show varices? Did they show portal hypertensive gastropathy? Because can you imagine how much would this case change in your mind if we know why he's having GI bleeding? It'll give us such a profound clue. Yeah, that jolt of an emotional moment on Twitter is alive and well 8 years, 7 years later, and I'm grateful for maybe that vitriol.
Robbie, if it was prehepatic, what
Yeah.
would then your DDX be? Like if we showed that this is like prehepatic portal hypertension.
Yeah, I think if it's prehepatic portal hypertension, Prof, the most common cause worldwide are two things: schistosomiasis, which you and I also have many fond memories about, and then the myeloproliferative neoplasms. And I think especially when you're entertaining the possibility of bone marrow fibrosis, as you said, MPN-related diseases are loom large. And then, the subtle hint, Prof, that this is chronic. And the subtle hint that the B12 is elevated. And the B12 is elevated in these patients with MPN because they abnormally express the B12 receptor on their cells. So yeah, that's where I would lean is the prehepatic plus marrow fibrosis. Very, very concerned for a myeloproliferative neoplasm. It wouldn't explain the kidney involvement. It wouldn't explain the hypothyroidism. So those are the gaps in that line of reasoning for sure.
And one more question for you. In the
Yeah.
MPNs, which one would you then prioritize?
I think that myelofibrosis is the rarest one, but I think it's the most likely one to have such massive splenomegaly and such deep cytopenias. I would hope for the patient's sake that that's not. But you remember you presented to me a case of prefibrotic myelofibrosis on RLR quite some time ago, a very aggressive course. So yeah, if I were to if it's that, I think my guess would be either this is compensated P vera, um, or myelofibrosis. But yeah, I think it's predicated on proving the port. If there's no portal hypertension, both these hypotheses I think really fade to nil, almost nil. All right, Zachariah.
Okay, so I think first to answer Prof. Rez, he intermittently had very mildly raised CRPs and ESRs, but it was really borderline as well, and for the most part was normal when done. In terms of the workup for his GI bleeding, frustratingly, I don't have the actual reports. I know he was seen by gastroenterology, and based on the final diagnosis, I'm quite confident that the patient had portal hypertensive gastropathy on G-scope and had rectal varices on colonoscopy, but I can't actually confirm that. In terms of his hepatitis panel, it was negative. His HIV test was negative, and his schistosomiasis IgG was positive. And I'll stop there. There'll be one more anecdote before the final diagnosis.
Robbie, I can comment on that. I think you have to be really careful with positive antibodies because we all, especially depending on where you are in the world, are likely going to be exposed to so many types of infections. And it's almost like a patient who has an MRI performed and you're trying to evaluate for a neurologic syndrome and something shows up positive, you have to ask the question, does it match the presenting syndrome? So by no means does the positive IgG confirm schistosomiasis leading to this devastating presentation. Really, in order to make that diagnosis as a cause of the portal hypertension, I would prefer IgM. Maybe there's Carius testing now, maybe there's advancements, but if you do a biopsy of that liver and you evaluate for the pre-sinusoidal space, you'll see actually eggs there. And that sort of confirms the diagnosis of schistosomiasis. Robbie and I are really, really well versed in it. So I don't know, and I mean, I guess I do know a lot about schistosomiasis based on that paper we published and the hours that we spent. Um, but it just, I like your theory more, and I don't think the IgG is enough to say this case is closed by any means. But I'd love to give the mic to you as you were feeling the possibility of portal hypertension to continue carrying your thoughts forward.
No, Professor, I completely agree with the caveat that you said about the schistosomiasis. It's a reasonable diagnosis, but I think that it's not actionable. Unfortunately, if you have schistosomiasis that's this advanced, it's not treatable. It also doesn't explain the teardrop cells in the marrow, and it doesn't explain, as far as my knowledge, the massive hepatomegaly, because the schistosomiasis eggs lodge in the hepatic portal venules, and they leave the liver small-ish or normal. So I think, would I accept it as a final diagnosis? Definitely, but only after you rule out the other the most common cause competing with schistosomiasis. My mom insists on saying bye to me, even though she's going for 20 minutes. Bye. 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 Au revoir. She says au revoir, Prof. Rez.
Au revoir, à tout à l'heure.
À tout à l'heure.
À tout à l'heure. Oh man, she's gonna question my French speaking skills now.
No, Prof. She sent me another request. She completely forgets that you have no idea how to speak more than basic French. She asked me to translate another French thing by you, but I'll spare you the details. I forget what I was saying. I think, schistosomiasis, myeloproliferative neoplasms are the two most common causes. And I think you should get I would consider a bone marrow. And if the bone marrow is negative and the JAK2 and all the MPN mutations are negative, I would accept the diagnosis. But I think since the myeloproliferative neoplasms are treatable and very, very morbid, I would not land on schistosomiasis without disproving it. And I'm just going to say one quick thing about the beginning of the case, because I'm always a big fan when we're nearing the end to go back to the beginning. The GI bleed and pancytopenia. And I think my initial reflections are maybe a little bit imprecise, because I just realized halfway through the case that I see GI bleed and pancytopenia all the time, even though I said it's rare, because I see patients with cirrhosis who have pancytopenia and a GI bleed all the time. And it's amazing how, when the patient doesn't have obvious cirrhosis, completely ignored the real pathophysiology. What connects GI bleed and pancytopenia all day, every day for me in real life is portal hypertension. And so I think that the truth is that if we're aiming to be the best version of ourselves, we see this disease play out all day, every day in the world with cirrhotic portal hypertension. So I think was there the ability to suspect portal hypertension from the get-go? Absolutely. Now you're just seeing a very sneaky version of portal hypertension, which is prehepatic portal hypertension, do this. So yeah, I think just to end on that, just to at least end the initial reflections on that is next time when I see GI bleed and pancytopenia, I'm going to remind myself I see this all the time, and to be open to the fact that the patient may not have cirrhotic portal hypertension, but to quickly investigate for non-cirrhotic portal hypertension quickly. Quick look at that prior endoscopy report and go. So I just wanted to share that reflection, but I'm right there with you. I think schistosomiasis is an acceptable answer, but only after we do a little bit more work. All right, Zachary, I'm back to you, my friend.
Wonderful. So the final diagnostic test that had been done was a liver biopsy that showed preserved hepatocyte architecture, no inflammation or evidence of cirrhosis, but prominent portal-based fibrosis with ductal plate malformation, pathognomonic for the diagnosis. And I'll stop there.
This is a great opportunity to tell you that I have absolutely no idea, but I know exactly how to figure it out. Ask Prof. Rez to see if he has any thought.
I thought you were going to say to ask GPT. This is so I think again, Zachariah, like this is such a well presented case. Like you've given us every opportunity to get to the bottom of this. And as I'm saying all this, Robbie's going to be inputting this into GPT. But something else that sort of amazed me was the fact that you've like shared a decade story in 30 minutes and you did it flawlessly. I have no idea. So what we see there is that there is no cirrhosis, which we had a low pretest for based on all the data that you shared. What we're seeing is fibrosis, correct, Zachariah? That's in sort of the vascular space, the prehepatic space. And I think to Robbie's point, that fibrosis is leading to the prehepatic portal hypertension. It's also somehow, whatever this disease is causing the liver to be enlarged, and it's probably causing fibrosis in the bone marrow. I still don't know. It's not like you saw an egg or something. I know that there could be some architectural abnormalities with schistosomiasis, but I like some kind of fibrotic process that's leading to all this. Robbie, any thoughts?
Yeah, Prof. Rez, I think that the only thing I have the buzzword is the preservation of the hepatic architecture is such a buzzword for schistosomiasis because the idea is that the eggs that you masterfully drew lodge in the hepatic venule and then they spare the liver. But I actually don't know what the ductal plate malformation implies. So I think the good news is that an easy a search on ChatGPT or open evidence will give you the answer. But I'm now more and more open to schistosomiasis, especially if the teardrop cells go away. I don't like those teardrop cells. Yeah, but that's where I'm at. Zachary,
Yes.
back to you, my friend. Enlighten us, please.
So the finding of ductal plate malformation is pathognomonic for the diagnosis of congenital hepatic fibrosis, which led this patient to have severe splenomegaly, leading to hypersplenism, causing pancytopenia with the bone marrow trying but failing to mount an adequate response.
I was just gonna say, that's like crazy, Zachariah. It almost leaves me speechless, but what I love so much about our discussion is that the link between portal hypertension and gastrointestinal bleeding, I think that's a very strong link. But then never forget, we said this is a decade-long process, which made us lower the likelihood of infection and cancer right off the bat. And don't forget, if you go back and listen, we said 30 years old, we're worried about something genetic. And we also said, whether it was myelofibrosis or TAPRO, we said we're worried about a fibrotic disease entity. I'm not trying to give a speech as to say that we were on the right track, but I think, Robbie, we were deducing the answer to this problem very eloquently, like on a condition I've never heard of, being able to get to the root cause of the pathophysiology of that, hey, something's causing fibrosis. This is a young person, it's 10 years long. It's less likely to be a rip-roaring infection or cancer. Um, I have to reread a congenital hepatic fibrosis. That's so cool. I mean, how did the patient do, Zachariah? Was it like a liver transplant, or how do you treat this?
Yeah, so I think the first thing for this patient was this diagnosis had actually been made in 2018. He'd had the liver biopsy back then, but unfortunately, either the diagnosis had not been properly explained to the patient, or due to him having moved around, he had been lost to follow up. And despite him being hospitalized every year and getting so many transfusions, the answer wasn't in being a brilliant doctor and knowing a lot. And it was simply just to go home and sit on my computer for an hour and hunt through the lab work and stuff to find all of this. As a patient, it had multiple folder numbers. And because of us now actually having a diagnosis, we discussed with the interventional radiology. And the patient is going to go to gastroenterology hopefully next month for review. And if they give the go ahead, then the patient will hopefully undergo a splenic vessel embolization, which will hopefully improve his cell counts without putting him at the risk of becoming asplenic and the immunocompromise that results from that.
Guys, this has been such a treat. I think every time you present Zachary, and every time I have the privilege of co-discussing with Prof. Rez and my mom, it's always such a treat. I always learn so much. I think I want to share with you a picture for two reasons. The first is goes to show you that when Reza and I got to know each other and started to love and fall in love with clinical reasoning, we started to build these schemas. And I will tell you that for those of you who look at those original versions of that work, I will tell you that the process is endless. And I was texting Prof. Rez that your ability to learn medicine will never end, and you'll always learn and grow. And so I will share with you my growth over the last 5 years in taking the pancytopenia schema that you see published on CP Solvers to having so many different sub-schemas with filters and whatnot. And I'll just show you this. So this is the problem we had today. We didn't have pancytopenia. And the only thing that has chronic cryptic pancytopenia with splenomegaly, prehepatic portal hypertension. Now, there are all these other things you can look for, right? So why do I share this with you? I don't share this with you to flaunt. I share this with you to show you that you can continue to learn medicine forever and ever and ever and ever. Never think that you're done learning. But also, number two, out of humility, that I completely forgot this schema, even though I probably spent an hour thinking about it, reading about it, putting it together, scribbling it, drawing it, making the handwriting pretty for publishing maybe someday on RLR CP solvers, which you should check out. But the learning is endless, but the forgetting is also endless. And you constantly have to expose yourself to be able to retain what you learn. So I literally spent an hour putting this together, but I completely forgot that simple rule. But how much more likely are we all to have our neurons that more sharp for the next time something like this happens? And it won't be super rare. So really, really appreciate the rep, Zachariah, and the dancing preference. It was a real fun hour. Len, thank you for scribing. A lot of work today, and I'll hand the mic to Eugene to take us home.
It's been a ride and a roller coaster. I don't know where to begin from. So we have a young patient who came in with recurrent GI bleed, and also we got to know that there was upper GI bleeding. He also had recurrent pancytopenia, And then eventually on examination, we got to know there was massive hepatosplenomegaly. So first off, Dr. Rabih mentioned that it's quite difficult to diagnose a GI bleed unless you've seen it on endoscopy. So would you be considering it as noise in this particular case or flavor? And picking upper GI bleeding, your mind goes to a pre-hepatic, intrahepatic, or even post-hepatic cause of portal hypertension. And then we still wanted to understand what is causing all the cell lines to be down. So we picked pancytopenia. Our approach was that that is the most certain most certain finding that we have on the patient. So it's important to understand if it's contributory to the GI bleeding or the GI bleeding is a standalone. And Prof. Rez explained that when you have one cell count down, you usually would think about loss or destruction. If you have 3 cell count down, you should consider marrow underproduction or splenic sequestration. 2 cell count down may be either or. And then he honed on the pallor that with severe pallor, it speaks to the degree of anemia and it supports a slow process other than an acute loss. And in this case, when we got to, the chronicity favors hypersplenism. And the fact that there was no stigmata for cirrhosis does not necessarily rule out portal hypertension, because he mentioned that you could have atrophy of the testes. That could also be a sign of portal hypertension. It may not be as a stigmata on the abdominal exams. Then we try to pick the 3 findings to think through as our unifying symptoms. That's a GI bleed, pancytopenia, hepatosplenomegaly. And Dr. Rabih explained to us that if you're approaching organomegaly, you first have to consider whether it's a focal mass or it's homogeneous enlargement. And when you have 2 organs, it's very simple to think of homogeneous enlargement because it's not very likely to have a focal mass in 2 different organs. And so when we think of hepatosplenomegaly, you're thinking about causes could be from either fluid congestion or an infiltrative process. So for fluid congestion, typically it's from the portal circulation. So it goes back to support our first finding of the upper GI bleeding, which brings our minds to think of portal hypertension. We still thought about infiltrative process where you can have white cells, red cells, or even microscopic proteins infiltrating the liver and other organs. And so we went, he mentioned that to make progress, you want to do imaging. So POCUS, if you do a POCUS and you see fluid in the abdomen, that can tell you that it's congestion. But on physical exams at the area of the skin, if you palpate lymph nodes or even you see lymph nodes in the mediastinum on imaging, you could start thinking about an infiltrative process. Then we got a previous biopsy done years ago, and Prof. Rez explained that the hypercellularity just suggests that the bone marrow is compensating for some process that was going on. But a teardrop cell was where we started thinking, could this be as a result of something infiltrating the bone marrow? And so the cells that are being produced, being forced out, are forming teardrops. And our mind went to myelofibrosis. So we had two things for our unifying hypothesis. That is, we have, due to the nature of the massive hepatosplenomegaly, symptoms supporting portal hypertension, we're thinking about a prehepatic or intrahepatic non-cirrhotic portal hypertension and the myelofibrosis. Those were the 2 things that we started thinking about. And it was important for us to investigate the cause of this particular non-cirrhotic portal hypertension. And things that popped up was that this could be a genetic cause because of the patient's age, which eventually was our diagnosis, or it could be portal vein thrombosis or a schistosomiasis. We did have IgG, positivity for schistosomiasis, but it ended up that this was a genetic cause, which was a congenital hepatic fibrosis. So packed with a lot of learning. And I always love Zacharias cases because it comes with so much learning that you don't know where to actually pick from. And I'm so excited to be a part of it today. Yeah, thank you.
Eugene, that was incredible. That was so good. So if you're on YouTube, just fast forward, though you won't hear this now, Fast forward to Eugene's part. Ignore everything that I said. And Zachariah, thank you for like presenting one of my favorite cases. And Robbie, you've been up for more than 20 hours now. And thank you for being here and riding with me because I don't, dude, if I had to do this solo, it'd be so difficult. That link of portal hypertension to GI, that's such a great pearl for all of us to take home with us.
You got the genes and I got the anatomy, and together we got close. Although we'll never get Zechariah, try as we might. Thanks everyone. See, have a great rest of your day.